So we talked about it just a little bit, but there are different stages of sleep. So we have stages 1, 2, 3, and then stage 3 that's deep, and then we have what's called REM or rapid eye movement. So when we look at the different stages, this is kind of a light sleep. This is a light sleep, and may not even actually fully be asleep. And so when we look at this, this is slow rolling eye movement, respirations are regular, heart rate and blood pressure start to decrease a little bit, and you may have a little bit of a snore. When we look at stage 2, either you have slow eye movement or the absence of eye movement, your heart rate, BP, respiratory rate, and temperature all start to decrease, and snoring may occur. If the patient is woken up, they may be thinking that they are having a daydream in this moment. So when we look at stage 1, they're not going to feel like they were asleep at all. When we look at stage 3, there's no eye movement. The heart rate, respiratory rate, blood pressure, temperature, and oxygen consumption all start to go down. You could get some snoring. This is where dreams might happen and the sleeper becomes more difficult to arouse. So it's more of a challenge for them to wake up when it comes to stage 3. In stage 4, there's no eye movement. The sleeper is very relaxed and seldom moves. Vital signs are at their lowest, but still a normal level. Oxygen consumption is low. The patient is very difficult to wake up, but this is where we see that the patient may have some bedwetting or night terrors or even sleepwalking that's associated with the stage 3 deep sleep. Then we have this whole kind of flip of the body when we're in this REM or rapid eye movement staging. So your respiratory rate increases, but it becomes irregular and shallow. Your heart rate and your blood pressure start to increase, and there's a paralysis of most skeletal muscles. And some clinicians seem to think that this is because this is where we are dreaming the most, is in REM. And sometimes we're more fighting off bears or fighting off being captive, or our body just wants to kind of sit and enjoy the moment in that dream instead of actively participating in it. So if I'm fighting off bears in my dream, I wouldn't want to like kick and hit my nightstand and then wake up with with a knot on my shin as if I just kicked it. So it's really interesting to see these different stages. If you have questions about these are very just superficial levels of staging. We can get into more of that staging and that criteria at a later time. When we talk about treatment, there are a number of different things that we can do. In general, with OSA, sometimes those risk factors that we have with the really thick neck or the sedatives, alcohol, those medications, if we change the behavior, if we can adapt, maybe adjusting the patient's caloric intake or increasing their activity level, we can change the size of their neck and we can decrease the amount of weight that is pushing on those anatomical structures. If it's something that needs more information, whether it's a substance abuse hotline or some therapy in that regard, that can happen as well. We can definitely do that, and we can have the conversations with the right team to get the right treatment for these patients. With obstructive sleep apnea, they could use a number of different things, right? We could start with oral appliances. So there's a custom mold or a custom fitting that these patients could wear that will rearrange where the anatomical structures sit while they're at sleep. So this could push the jaw forward, creates a little bit of a jaw thrust. This could keep the tongue pulled forward so that we can not allow that tongue to create an obstruction. It could maintain the soft palate so it's not collapsing on the airway. So the next step up may be using positive pressure ventilation, whether that's CPAP, BiPAP, or what we call ASV, or an algorithm calculating target ventilation. Patients can end up with surgery to remove any upper airway obstructions or lesions, they could have a tonsillectomy. That would be kind of a more familiar one with it. There's even a surgery for the uvula, and that's the uvuloplatopharyngeoplasty, or what's called a UPPP. Whew. And this is a very common procedure when it comes to treating snoring and sleep apnea. Then there's laser-assisted uvuloplasty. There's radiofrequency ablations. These are typically less invasive than the UPPP. And there's other surgical procedures for OSA, like a septoplasty, a rhinoplasty, nasal turbinate reduction, nasal polymectomy, palatal advancement, pharyngeoplasty, lots and lots of reductions and removal of anatomical features that could be causing the obstruction. Then there's what's called implanted stimulators, and the most famous one that we know about right now is Inspire. Inspire is an implantable upper airway stimulator that delivers a mild stimulant to the hypoglossal nerve, which is our 12th cranial nerve, and it moves the tongue forward during inspiration without disturbing the sleep. So in select patients who are refractory to CPAP therapy, this device has some promise. So I know that there's a lot of people that are like, well, why would I have to wear this full-blown appliance on my mouth and my nose when I can get a surgery for this implant? Well, the implants aren't for everybody, but they're basically a diaphragmatic pacemaker, or they are a nerve stimulator that repositions anatomical features so that during inspiration there's not an obstruction. The other thing is with central sleep apnea, again, we have patients that have the primary and the secondary. If it's primary, we don't know the origin, it's idiopathic. If it's secondary to a different condition like AFib, or patients with congestive heart failure that have Cheyne-Stokes respirations. So these folks are going to end up with CPAP or ASV, or algorithm calculated targeted ventilation, or varying positive airway pressure, especially with those patients that are in Cheyne-Stokes breathing. So remember, Cheyne-Stokes breathing is a period of apnea. It crescendos and then it decrescendos, and then a period of apnea. So if I had set pressures that entire time, well, if the patient during their period of apnea is not triggering the machine, they won't get their breath, right? But during the times that they are breathing, they have that crescendo where their effort increases, and their rate increases, and then it falls down. Well, I don't want the exact same pressure if the effort is different from the patient. So that's where you start to get this varying targets of ventilation. So ASV and VPAP are really, really good for those hyperventilation related central sleep apnea, especially those Cheyne-Stokes patients. Now, when we look at hypoventilation, this is simply the diaphragm not moving, or the brain not sending the signal to the diaphragm to move because, hey, I'm oxygenated. Hey, I'm trying to sleep. Let me just take a break, and I'm not going to do what I'm designed to do by stimulate the diaphragm to move. So these patients, they need a backup rate. Despite them making efforts, at some point they're not making efforts, and they're going to need that rate to help compensate for when they aren't making those efforts. And then we have the VAPS, which is very similar to AVAPS. We're optimizing the pressure support to target a exhale tidal volume or a minute ventilation. These are the folks that we definitely want to make sure that they are getting what they need and not just what we set. So lots of different potentials when it comes to treating OSA versus central sleep apnea. Then there's the opportunity to oxygenate, and we can bleed oxygen into the supported devices, whether it's a BiPAP, CPAP, or that ASV, because the BiPAPs themselves, the home units, the CPAPs themselves, they don't provide oxygen. What they do is they provide pressure. Now, the devices that we're used to seeing in the hospital, they are able to create that pressure by delivering oxygen. So, when we use these home units, they do not typically provide the pressure from adding medical oxygen. They use the ambient air and deliver 21% or room air to the patient while providing positive pressure. So sometimes we have to bleed in oxygen for these patients if they have not only hypoventilation but also hypoxemia related events. The other thing is we can use some pharmacological therapies and some respiratory stimulants. The ones that we're going to see most often are our methylxanthines. Methylxanthines. And what these are designed to do is they're designed to stimulate the diaphragm so that it continues to move. Caffeine would be a methylxanthine, but it's hard to take caffeine and try to go to sleep. There's theophylline. Theophylline would be another example of a methylxanthine, but your methylxanthines are respiratory stimulants that we can use for obstructive sleep apnea or central sleep apnea. So that's our talk when it comes to the sleep-related disorders. I know that the NBRC actually has a test specific for sleep disorder specialties. So this is an avenue, and this is a career path that clinicians can jump into and get more information on. And what's crazy is there are so many links between a healthy sleep life and a healthy life. So if you can maintain your sleep health, you can maintain other areas of health as well. So sleep is very, very important, and we need to make sure that we are tapping into and understanding the events that are associated with circadian rhythm and how that impacts and how that improves healing. All of those are further questions that you can delve into to further explore and gain some more understanding when it comes to sleep disorders. So we'll see you on the next one.